This is the Get Healthy 360 podcast, where we discuss topics related to your physical, mental, financial, and spiritual health. Your host is Dr. Kris Ferguson, board certified in anesthesiology and pain management. This podcast is for informational purposes only, and you should consult your primary healthcare provider before making any decisions related to your health. And here's your host, Dr. Kris Ferguson. Oh, one more thing before we start. If you like this episode, please consider rating us 5 stars. We would really appreciate it. Thanks very much.
Welcome to Get Healthy 360. Today we have with us Dr. Nomeen Azeem. He is a world-renowned pain physician, published many articles, textbooks, and he just recently published a textbook, How to Treat Back Pain. So what he'll be doing is explaining his treatment approach to low back pain that really is the standard of care. He completed his undergraduate education at James Madison University in Harrisonburg, Virginia. Then he graduated from medical school, earning his doctorate of medicine from Ross University School of Medicine. He then went on to Georgetown University Hospital, Physical Medicine Rehabilitation in Washington, D.C., where he was the chief resident. After filling in as a faculty position at Medstar Georgetown University as a musculoskeletal specialist, he went on to complete an ACGME interventional pain fellowship at Temple University Hospital in Philadelphia. He's internationally known and well regarded, so we're lucky to have him educating us today on his approach to low back pain. And I'm sure we'll be talking about a lot of things many people have not even heard of, but offer excellent treatment options for your spine. Doctor, thank you so much for joining us today.
Thank you so much for having me.
So let's just dive right into it. Someone has low back pain, they come to your office, and let's just say they've tried the normal things. They've tried over-the-counter pain medication like ibuprofen, Tylenol. They saw their family practice doctor. They tried some physical therapy. They tried a chiropractic care, and their family practice doctor said, you know what, you have back pain. I'm going to send you to a pain doctor. When people go to a pain doctor, normally they think, oh, you're a pain doctor. Give me a bunch of pills. What are your thoughts on that?
Yeah, so there's been a huge paradigm shift. I'll tell you, I started practicing approximately 11 years ago. And I feel like at that time when we used to have patients come in with all kinds of pain issues, especially low back pain, with chronic low back pain being the #1 pain complaint in the United States and actually in the world. But 11 years ago, a lot of patients would come in and say, hey, I don't want to mask the pain, whether it's pain pills or whatever, I just want to fix the problem. And before I could even get a word in edgewise, they say, I'm just going to go see a surgeon and get this fixed. And over the years, obviously we all know about the opioid epidemic and how, all the different factors that led to, overprescription, overutilization, and abuse of those, medications running rampant. So now when people come in, you have to have more of a comprehensive, thought process. So just to your point, if somebody comes into my office and they've had, the physical therapy already, they've tried the non-opioid medications like over-the-counter things like anti-inflammatories, maybe the referring doctor has already prescribed them things like muscle relaxers or neuropathic agents, if it's appropriate. A lot of those things have already been tried by the time that most interventional pain doctors see these patients. And so really everything starts with a good history, right? Every patient that comes in, we want to take that history. So not just knowing all the background of what they've had done thus far, but then also, tell me about your pain. Describe it to me. When does it bother you the most during the day or during the evening? What precipitating factors and aggravating factors? What makes it better? All of these types of things. And also, you really want to, as a pain specialist, you want to be able to differentiate between pain that is nerve-related, muscular, inflammatory, because it'll help you to come up with a more appropriate plan to target that pain more appropriately. And if you can target something appropriately, you have the best chances to have the best outcomes with knocking it out. So sitting down and taking your time, I think in medicine in general, we've gotten into situations now where most doctors just running, they're on rollerblades, like from room to room to room. And, there's so many factors that have caused that. But I think for patients that have chronic pain, chronic low back pain specifically, there's so many factors that are involved. There's so many things, like your spine takes like decades to degenerate, right? By the time that we're seeing most of our patients, it may not be a singular problem, it may not be a singular source. It may be overlapping pain generators, and we have to sit down and ask them all these questions. So that'd be the first thing, is getting good history, and then really following that up with a really good, sound physical exam. There's a lot of provocative maneuvers, things that can provoke pain in different postures, checking range of motion, doing good neurologic exams, seeing if people have, numbness or weakness and things like that in different areas. That can really help guide your treatment plan moving forward. So once that's done, then the next thing really is any kind of appropriate diagnostic imaging. So what I mean by that is, get an X-ray, like for the spine specifically, the MRI is going to be the gold standard. If the patient doesn't have any limitations, then I'm really going to try to start out with an X-ray and or an MRI to now support what I've already figured out with a good history and physical exam. And so once that's done, have the patient come back and review the images with them. And I really feel like if you're sitting down and you're talking to the patient and you're really paying attention to them, go over the images with them. Don't go over the report. They can read the report. They may not understand everything, but it's really important to sit down and actually show them the images. Show them that you know what you're talking about so they can trust you, but then also try to help them understand, well, here you go. Here's a disc that's herniated out and it's sitting on a nerve. So that's why you're having this pain shooting down into your leg, like from your leg into your foot. Or look at these joints in your spine. The joints have excessive fluid in them, and that denotes an inflammation. And this correlates with your physical exam. And when I was like kind of bending you back to this side and that side, and you're having pain, well, now I can show you on this MRI that this is consistent with your physical exam and also how you're describing your pain. So when you sit down, you take your time to do that with these patients. I mean, it really makes a world of difference. So you want to be comprehensive, but that's where everything starts. The foundation is sitting down, taking time, explaining things to your patients. This mantra, treating patients like family, we take it to heart at our practice, but realistically, it's about how you treat the patient in general, not necessarily just like family. I don't know, Kris. So people like or dislike their family, so I don't like to use that
That
example
gets
term.
complicated.
Yeah,
That gets
right.
complicated.
Yeah.
Like their families are not.
Exactly. So for me, it's just the more that you sit down and you explain things, like I want my patients before they leave my office to understand as much as I can convey to them, like what is actually going on with your body? Why am I choosing to recommend, a certain procedure, a certain minimally invasive surgery, whatever it is. But I want them to understand my logic, as best as they can, and when they understand that, the trust is there. And honestly, there's been many studies that have been done that show that the more the patient trusts you, the more the patient understands, the better your outcomes are going to be. There's no doubt. And also temper your expectations, right, with the patient. So this procedure is supposed to do A, B, and C. It may take this long for you to see the full results of it. We may have to circle back and go to physical therapy again to strengthen everything around a structure that has been, degenerated and weakened over time. So there's a lot of different moving parts to it. But again, I think taking your time with the patients where it starts.
And I know you have a whole textbook on this. You spent your life like really mastering treating pain and back pain. So it's hard to condense this into a short podcast. It's like asking a master chef, "Hey, teach me how to cook." And you're like, "Well, where do I start?" So it's a big topic. So to boil it down, people have a general idea of what surgery is. You go, you see a surgeon, they cut on you, they can fuse things, they can remove discs. They have a good idea of what a chiropractor is. They go in and they adjust you, and it is what it is. But when people typically think pain doctor, they think some sort of steroid injection, or they refer to everything that a pain doctor does as an injection. But as we both know, an injection is just a misnomer for a lot of different types of procedures. Can you elaborate on some of the things beyond steroid injections that could be on the table to treat someone with pain?
Oh, absolutely. I mean, I think steroid injections have been the go-to procedure for a lot of pain doctors for many, many years. I mean, decades. I mean, they're kind of the foundation of interventional pain for a very, very long time. I would say that, that field has evolved, into new realms where there's more advanced procedures. But I mean, at the essence of it, the goal of interventional pain and pain management is really to try to block that pain signal. Okay, so the idea of a steroid injection is introducing a steroid, which is an anti-inflammatory, into a space, enclosed space, so that it can decrease inflammation, whether that be around nerves, whether that be in joints, whether that be sometimes, in muscles. And that's the purpose of that. Then if you get more advanced than that, you're looking at different ways to block the nerves that are sending the pain impulses, the dysfunctional signals to the brain. Things like radiofrequency ablation, which that technology has been around for about 6 decades now, and utilized in other fields like cardiology, interventional cardiology, same purpose to disrupt, an abnormal signal in the heart. In the spine, we can utilize these radiofrequency ablation type procedures to again block that pain signal. And it's not a permanent solution, but it does give pretty long-term relief, especially when compared to things like steroid injections.
Can you explain, just to jump in, can you explain to someone who's listening, who's either, let's say, a family practice doctor or a non-pain specialist, what is a radiofrequency ablation?
Right. So radiofrequency ablation is still using needles. So we're not talking about an open surgical procedure, but essentially what you're doing is introducing a needle along the long axis of a sensory nerve. And what you want to do is place it close enough using fluoroscopic guidance, whereas, the tip of the needle is actually going to heat up and it's going to denature the proteins of the nerve on the surface. So you're not killing the nerve or destroying the nerve. What you're doing is you're interrupting its ability to send that signal, that abnormal signal. And so that's why it's not a permanent procedure, because you're not killing the nerve, you're not destroying it. What you're doing is you're actually just taking the outside, fibers, and you're essentially cauterizing the outside surface of it and disrupting the proteins there. And what happens is, eventually you have Wallerian regeneration, which for anybody that's gone to medical school may remember that from neurophysiology, but essentially the nerves will regenerate and they'll bridge that gap eventually. And then that's when the pain will come back. But again, the time, interims between radiofrequency ablations will last anywhere from 6 months to 24 months, and the literature is kind of all over the place with that. I know in our practice, we typically get about, 12 to 24 months out of that procedure if it's done with good technique. But it's a great option for any kind of joint related pain, whether it be, the joints of your neck, the joints of your low back, knee joints, hip joints, shoulder joints. There's seem to be more and more indications that are, that are coming out for radiofrequency ablations. The biggest key to that is that you really want to focus on nerves that are sensory nerves or mainly sensory nerves, because if you think about denaturing a nerve or blocking a nerve, you have the sensory nerves that send, sensation signals, including pain, but then you also have motor nerves that control your function. What you don't want to do is block a functional nerve and cause any weakness. So you got to be careful about being as selective as possible with the nerves that you are ablating.
So then, so what I'm hearing is you put needles in, and these nerves or the needles heat up and essentially stun the nerves that are causing pain in your back.
Right. They're essentially getting a long-term block on a nerve. So if you put numbing medication over a nerve, you get a temporary block. If you do an ablation, you're heating up that nerve and you're putting a physical block on it. So I equate it with my patients to like cauterizing a wire. The only thing is this wire is alive, so it's going to regenerate.
So then beyond the radiofrequency ablations, which is still a well-established technology, what are some of the new things you talk about in your textbook?
Yeah, so there's so much. The field is evolving at light speed. So one of the things I'll kind of allude to is for the longest time in both interventional pain as well as in spine surgery, we've been looking for solutions for pain coming from the disc, right? So everything from, different kinds of open surgeries with spine surgery, more recently disc replacement. Well, in our space, what we've done is trying to find different injectables that we could potentially place into the disc that can help to either restore the disc, rehydrate the disc, so on and so forth. And the idea is this: is the disc itself in the spine is a shock absorber. That's what it is, and it helps to dissipate the shocks of every, day living. Like, so whether you're standing, you're walking, you're bending forward, or if you're exercising and jogging, things like that, all that impact, it's absorbed by those discs. Over time, the disc, just like everything else in your body, degenerates, right? Your body's a machine, and unfortunately, it does break down. The discs themselves, the way that they degenerate is they lose that cushioning of absorbing ability over time. And so some of the procedures that have come out, in the last like 5 to 7 years, are trying to restore the function of that disc. So whether that be regenerative medicine, things like stem cells and PRP and things like that, or mesoblast, or non-regenerative medicine. So there are different allografts of proteins that break down in your disc that you can replace by donor tissue. So there's a lot of different procedures that are coming out that are targeting the disc now, and we're seeing really good studies and really good evidence showing safety above all else, and then of course efficacy. So I think over the course of the next like 3 to 5 years, we're going to be inundated with a lot of different interdiscal options. So that's one thing. Spinal stenosis. I mean, that is something that most
Can
everybody.
let me just, I have a couple
All right.
quick questions because I know people want to ask. So if either a patient or let's say a family practice doctor, how would they identify if the pain is coming from the disc versus like quote unquote sciatica or pain shooting down their leg, like, or say those lumbar facets, or the facets are those little joints in your back that support it. So I would say on a basic level, the spine is like a three-legged stool, and the front is the disc, and you have these two little hinges in the back, the facet joints, holding everything up. So the facet joints are held up in the back, and then the disc is in the front. So how would you tell with a history or physical exam the pain is coming from your disc?
Right. That's a great question. So what I would say is this, intradiscal pain is going to be pain that comes when the pressure in the disc is higher, right? So there was a textbook that I remember I had to read when I was in fellowship, is by Kirkcaldy and Willis. It's a great textbook on the biomechanics of the lumbar spine. In that book, you had different postures and intradiscal pressures and how that impacts the disc. So, for example, when you're standing versus sitting, right? When you're sitting, your intradiscal pressure is higher. So, if a patient has a degenerated disc that is painful, you're going to have more pain when you're sitting for long periods of time or when you're bending forward. Okay. The opposite is true for facet joints. Facet joints are going to be more so they're joints. So when you're bearing weight on them, so standing, or walking, you're going to have more pain back there, or extending your back instead of flexing forward. So it's actually the opposite, and so that's how, with that history, that you'd be able to tell the difference. Physical exam wise, again, extension and facet loading would be how you identify facets versus forward flexion. So one of the things I always ask my patients to do is either there's something called a sustained hip flexion test, where I may have them lay down on a table and just kind of hold their entire leg up with hip flexion, and then kind of lower it slowly. If you can reproduce that pain back there, it's most likely because you're increasing that intradiscal pressure. The other thing is when we're talking about history, I'll ask for, kind of practical things with patients. Hey, does it hurt you more when you're tying your shoe, or when you're reaching under a cupboard to reach for something? And if they say yes, then I know that there's going to be, some element of discogenic pain. The other aspect is using that MRI to your advantage. So if we get the diagnostic imaging done, if you're looking at the disc and the disc is really, you know, um, it looks darker compared to the rest of the levels, then you know that that's degenerative changes. Okay, without getting into the nuances of MRI and a kind of a radiology lesson, essentially there is a T2 image where fluid ends up white, on the image, or lighter, right? So you can compare, let's say, an L4-5 disc to an L2, L3 disc, and there may be a stark difference between how light or how dark it looks. The darker it is, the more degenerated it is. And there you go. Utilize that to support your history and physical, and it's discogenic pain.
So that's a great synopsis on disc pain, which is the front, and the facet pain, which is the back. So someone comes to you, they have disc pain with leaning forward, that flexion test where they're doing their leg raise, and that's getting bad.
Mhm.
And then you're talking about these intradiscal therapies. So you've made the diagnosis. So can you expand on that a little bit more?
Yeah, so made the diagnosis. So then really it boils down to, well, a couple of different things. One is, unfortunately, insurance. Who's going to pay for what? Regenerative medicine, so things like PRP, stem cells, things like that. Unfortunately, there's not really any kind of, CPT coding. Like there's no actual procedural code that's covered like by AMA. So that there's not really anything there. So if you have a practice where you're able to do that and offer these types of procedures for cash, then you can go down that road with them, talk about the evidence there. There are plenty of studies that out there that talk about regenerative medicine and things like PRP and stem cell into the disc. Unfortunately, there's no big large scale study yet. And so I think that's what everybody's waiting for, is to see a good, like, RCT, some kind of double blind, type of multi-center large scale study. And I think then when that happens, I think we'll have a lot more, comfort with utilizing those, and maybe a code. Um, Beyond that, like, let's talk about allograft.
Mhm.
So there is a product on the market that is an allograft supplement. And what it is essentially, the center of the disc, as I said, it breaks down, right? And it becomes dark because you lose the fluid content. There's a type of protein called a proteoglycan that kind of holds the fluid in, right? When that breaks down, the fluid essentially dissipates and you lose that shock absorbing ability. So the allograft is actually taking those same proteins from cadaveric tissue, and you sterilize it, you pulverize it into a powder, and then you inject it back into the disc with some saline. And what that does is it actually brings fluid back into the disc. So it's not regenerative, it's restorative, which is completely different like paradigm if you think about it, because you're not trying to say, hey, we're bringing new cells into the disc or anything like that. We just want to restore the function of the disc. So, and that product does actually have some studies, and they're actually in the process of an RCT right now. So those are, I guess, regenerative versus non-regenerative are the two big wings. There's a few other markets that have not, or sorry, a few other products that have not hit the market yet that are still in phase one trials. And so, like I said, I think in the next 3 to 5 years we'll be inundated. But I do think that what's going on right now with targeting the disc, in lieu of a big surgery, we're taking the disc out and putting an artificial disc in. I do think it's very, very promising and encouraging that we have the technology right now that we and really the motivation to really focus back on the disc, and try to find different solutions that can halt the degenerative process of the spine.
Are there any other classes of treatment for the back that you'd like to discuss next that you've mentioned in your textbook?
Yeah, so you kind of alluded to it earlier. So we're talking about disc versus the facet joints in the back. So I'll kind of generalize that a little bit more. Anterior column versus posterior column, right? So anterior column includes the disc, but also the vertebral bodies. So there's also been a therapy that has been on the market now for about, I'd say, 4 or 5 years, where you can talk about radiofrequency ablation like we were before. You can ablate the nerve that actually innervates the vertebral body. When that is important is as the disc degenerates, because the bones kind of sandwich, the vertebral body sandwich the disc, right? When the disc loses that cushioning, you end up getting an inflammatory reaction at the edges of the bones that line the disc, right? And that in itself can be painful. So, if the bone itself becomes painful, then again, what do? You try to block the pain signal, and that's exactly what you do with this. So there's a basovertebral nerve, and there's a procedure that allows you to ablate that nerve. And unlike the other nerves, of the spine, of the knees, of the hips, and everything like that that do regenerate, there's not really a myelin sheath on the basovertebral nerve. So once you ablate it, it really should not regenerate. So that is actually a permanent solution if a patient is having pain coming from the bone aspect of the anterior column. Okay. So I think that's a great, I mean, that's a great procedure. It's also outpatient, can be done. Again, these are all, and the vertebrogenic pain or the pain from the bones in the anterior column, very similar to discogenic pain. It's actually one of the common questions that I get from a lot of doctors that when I teach is, how can you differentiate between, vertebrogenic or discogenic, like the pain coming from the bones of the front of the spine versus the discs in the front of the spine. And I'd say that's more difficult to differentiate for very, very experienced practitioners, even that treat spine all the time, versus like the facet joints, which is posterior column, versus the disc or the vertebral body. So that's a great one, that's for low back pain, and they actually have phenomenal studies as well to substantiate their therapy.
And then something new, new but not new, is the option of you have something called the sacroiliac joint in your low back, and you can do an ablation or steroid injection, but you can also fuse it.
Right.
So, what are your thoughts on those three treatment options? So, the sacroiliac joint, the joining of the sacrum and the iliac bones, so that movement can cause pain. So, what are your thoughts on those different treatment options?
Yeah, I mean, I think the sacroiliac joint is one of the most overlooked pain generators for the low back, um, even today. I mean, I think the statistics are staggering. It's about one third of low back pain may be actually coming from the sacroiliac joint, and that joint itself is instrumental. Like my background is physical medicine and rehab, so SI joint is right at the top of my mind when patients come in, but it's instrumental. Again, it's two different joints, one on either side, so there's a left and the right, but it's instrumental in pelvic rotation, and it's instrumental in activities like you getting out of your chair or going up steps or just your gait when you're walking, because your pelvic has to tilt forward a little bit for you to initiate the gait cycle. And so all of those activities are painful if the SI joint is inflamed. And to your point, Kris, yeah, I mean, traditionally, steroid injections into the joint, if they work really, really well, and they last a long time, you just repeat them periodically. The joint itself the joint itself is a diarthroidal joint. It's got cartilage in it, and again, the rotation is kind of like that. When you're doing these different activities and transitional movements. Um, there's a ton of ligaments that kind of hold this joint together. And over time, just like again, everything else in your body, like I alluded to before, those ligaments can kind of lose that tightness and they can get lax. And when that happens, you can start getting a little micromotion in there, and that causes inflammation. So a lot of times that can be due to everything from, previous spine surgery and the lower lumbar levels, which fixate the lower spine, and then you get undue stress on the sacroiliac joints. It can be due to falls onto your buttock. It can be due to women that have given birth multiple times, where the pelvis expanded and then recoiled, expanded and recoiled, and then again those ligaments just became lax. So again, things like physical therapy, you would want to start with. Even there's SI joint belts that you can wear that kind of hold everything together. But if all those things aren't working, then absolutely you'd move on to a steroid injection into that joint. And again, if you get long-term relief of that, then periodically you can do that. Physical therapy to strengthen everything around that joint to help the durability of the injection. Radiofrequency ablation for the joint has been, kind of a mixed bag of things. And part of the reason was that there's actually about 30 plus different techniques that have been published for the SI joint radiofrequency ablation. And so, the way that I was trained in fellowship is not the way that everybody does it. There's so many different variations. And a few years back, I'd say about 4 or 5 years back, CMS actually, started reimbursing for a specific code for SI joint ablation that AMA came out with. And just last year, they decided to go ahead and shelf that. So radiofrequency ablations of the SI joint are actually no longer covered by Medicare. They were always considered experimental by a lot of insurances, but every now and then, after a lot of back and forth, you could get that approved. So unfortunately, radiofrequency ablations of the SI joint are not even something that's feasible anymore in terms of the payers. Now, with that being said, it's kind of pushing everybody more towards the fusion, right? Now, anytime that you fuse anything, right, and you truly fixate it, there's potential for other things becoming hypermobile to compensate. Your body is a compensatory being, and as a PM&R background guy and a sports medicine guy, for me, I don't want to fuse anything. But with that being said, if something becomes so painful and so recurrent that it's really limiting all of your activities and really affecting your wellness and your quality of life, then you got to do something about it. So typically with the SI joint fusions, it used to be, a big surgical procedure where you could either use three screws or three metal bars that go across the sacrum, from the ilium all the way through the sacrum. And the thing was, like with those procedures, and they're still done. I mean, you're the patient's like non-weight bearing. It's almost like an inpatient procedure. You're non-weight bearing for a long time. A lot of risk for neurovascular injuries, things like that. Definitely not something that I think that most interventional pain doctors should be doing. But over the years, because of I guess more of the realization that the SI joint is a true factor of low back pain, there's been a lot of R&D and a lot of development of more minimally invasive approaches. So there's one approach, it's a posterior approach only, which I think for most pain doctors, it's very natural because just like we do SI joint injections into the joint from the posterior aspect, like from the back, the patient's laying on their stomach. The posterior approach is doing the exact same thing. It's putting a needle into the joint, and then you have some tools that kind of slide over the needle, and then you put either some kind of bone allograft or some kind of widget into the joint. And the idea is you stabilize the joint right away, right? So if you do that, your patients, one, they don't need to be non-weight bearing. They can, do like it's outpatients, so they go home, they walk around. But most of my patients, when we do that posterior aspect of this SI joint fusion, within a week or two, they're feeling better. You're not getting a fusion within a week or two. You're actually just stabilizing the joint. The fusion does happen, and there's depending on the product that you're using, because there's a lot of them out on the market. Some have graft windows where you can fill with bone putty, and that causes a fusion. But essentially, the idea is about stabilizing it. There's also been a refinement to some of the screw systems and things like that do go across the joint. I'd say the biggest thing with that is, you want to take the least invasive approach. You want to take the least risky approach. You want to avoid all the vessels that could get in the way, that could bleed out. So you really want to just choose appropriately. But right now is a great time for those types of fusion devices. There's actually now more than one code that you can utilize. And so far, there's been some pretty big studies that have been done, especially for the posterior approach, that liken the efficacy to the lateral approaches of yesteryear, but also show that the safety aspect of it, the safety profile is superior.
And I think one of the last major things to ask you about is I know I'm going to be respectful of your time, but the last things to talk about is typically people will think about spinal cord stimulators for pain after spine surgery. So correct me if I'm wrong. The numbers I'm familiar with is if someone has a spine surgery, like a third of people will get better, third will feel about the same, and a third will actually get worse or worsening pain. Spine surgery is a large invasive surgery that you may need, but understand, I feel like you may still have pain afterwards. But now there's been some advances where people are getting spinal cord stimulators instead of spine surgery for just that back pain. And I was wondering what your thoughts were on that.
Yeah, and kind of kind of circle back to how we started this conversation about that history and kind of trying to tease out what kind of pain the back pain is, right? So for example, if it's a mechanical pain from the facet joints, you want to make sure that you roll that out first, roll out the discogenic pain. If there is a nerve component to pain, then absolutely. I mean, neurostimulation, that's what it was developed to do, is to block nerve pain or nerve type pain, as well as sympathetically mediated pain, like complex regional pain syndrome and those types of things, even visceral pain. So if there's a component of nerve pain that's in the back, absolutely. I think Ken Chapman has a great article on using dorsal root ganglion stimulation for axial low back pain by putting leads at T12. I've had all my fellows read that over the years because he actually differentiates between the different levels that you would place a DRG stimulator, or at least the leads, like T12 versus L2, and how the sympathetic fibers run, at one level versus, the nociceptive fibers at the other. And so these are the nuances of how we've, been looking at way more indications than better ways to use neurostimulation. I mean, neurostimulation itself has been around, again, we're talking about 70 years now, going on 80 years, right? So, and we refined that. But to your point, I mean, I think for low back pain, when I was in fellowship, we actually did something called peripheral field nerve stimulation for axial low back pain, where we put two spinal cord stimulator leads kind of like sub Q across the back, and then we would have them do something called crosstalk, and we were able to block that pain that way. But now we have dorsal column stimulation that can be used for low back pain. There's a few really great studies that are out there. My good friend Tim Deers on a few of those studies. And so they're talking about dorsal column. Ken Chapman has a paper on T12 DRG. There's even peripheral nerve stimulators now that are, that have really good data with placing these leads close to the medial branches of L2 and, blocking the pain that way. There's a multifidus, which is a muscle in your low back that's used for stabilizing. And that weakens over time and can cause a lot of disruption as well as pain in itself. And there's a stimulator out there where you can, again, place these wire leads and then, stimulate the multifidus muscle and rehab that in a way where it solidifies the lower back again. So there's a lot of different options when using kind of an electroceutical essentially, and in order to block low back pain. I think it's an exciting time, and I think there's more and more again, research is going on into the different elements of back pain beyond the facet joints, beyond the disc. Like, what else is there that's causing this? The multifidus thing is amazing to me. Again, PM&R background for me, that is such an important muscle. In the past, when it's been, kind of dissected out for spine surgery, we now know, we look at that and say, wow, that's horrible. Other than, dissecting through ligaments, when that multifidus is compromised and it can't grow back, that destabilizes that low back a whole lot. So there's a lot of importance in not just the stability of the spine, but then also the pain generation of the spine.
So to close with, what's something that you wish people knew about, say, back pain that they typically don't? What's their takeaway?
Yeah, I mean, I think at the end of the day, what I would want people to know is that back pain can be very, very complex, right? So a lot of times somebody, I think just the thought process for the longest time has been, oh, I herniated a disc, that's when I popped a disc, I did this or I did that. And it may be a lot more nuanced than that. I mean, again, as a pain doctor for more than a decade now, I will tell you, even my understanding of the biomechanics of the spine and how these different pain generators interact, it's really changed the way that I practice on a day-to-day basis. I mean, now I'm not asking, the same questions. If I know that somebody's coming into my office and they have potentially multiple pain generators, I actually ask them, okay, what bothers you the most? Because you may have three different things, like an SI joint, facet joints, maybe the disc. All three of these are, unfortunately either degenerated, and it could have been like a domino effect, like one went down and then everything else followed. And it's, well, what bothers you the most, so we can kind of put you back together. So I think I want people to know that you got to trust the pain doctors, because we treat spine a whole lot. And, although we're not trained to fix the instability of the spine necessarily, that's not like our scope of training, we're very well equipped to figure out what the pain generator is and try to find some long-term solutions to knock that out. And if there's more than one, then sequentially knock out one, then the other, then the other. And really, it's an exciting time because we're getting more and more tools for our tool belt to address all of these different avenues.
Yeah, it's an exciting time to be a pain physician, and even better time to be a pain patient. Not that it's great to be a pain patient, but a lot more treatment options for that back pain. So, Dr. Azeem, thank you so much for taking the time for this podcast. In the podcast notes, We will have links to your book, and we'll also have your practice links so people can find you if they're in the Florida area.
Thank you so much, Kris. I really appreciate it. This is great.
Thank you again for taking the time.
Absolutely.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.